afternoon, everyone. My name is Brian Samuels, and I am the Executive Director of Chapin Hall, which is a policy research center focused on the most vulnerable kids and families. We appreciate you joining us this afternoon for the webinar, How to Improve Children's Mental Health. The material that we'll cover today centers on recent work with the state of Illinois around creating a blueprint for transformation. While there's little doubt that the pandemic took a toll on children's mental health, one study found that between March of 2020 to October of 2020, the number of mental health related emergency department visits increased by 25% for children 5 to 11 and 31% for children 12 to 17. This is data that comes from the CDC, and it clearly marks the immediate impact that the pandemic was having on young people. These issues aren't new, however. They've been around for quite a while. I was the child welfare director a long time ago, almost 20 years ago, for the state of Illinois. And at that time, I could give you a laundry list of challenges to getting the right kind of services for the right children at the right time. So today, we'll be talking about the plan for overcoming the systemic challenges to children's mental health. And the author of that report and the person that's been leading this work for the last 2 years is Dana Weiner, and I am glad to hand off the speakership to Dana. Welcome, Dana.
Thanks, Brian. And I'm going to share my screen here. As Brian said, I'm Dana Weiner. I'm a senior policy fellow at Chapin Hall at the University of Chicago, and I am also now the Chief Officer for Children's Behavioral Health Transformation. And I am thrilled to be here to talk to you about the work that we have been doing. Let me just check that you're seeing the right screen. Does that look good, everyone? Great. So I'm thrilled to be here to talk to you about the work that we've been doing. So let me just tell you what we're going to cover and introduce the panel, and then we'll get to it. In this afternoon's webinar, I'm going to give you some background and context for the Transformation Initiative, and then I'll spend the bulk of our time talking about our approach to analyzing the children's behavioral health care service system. I'll then turn to my esteemed panel, who I'll introduce in a moment, to talk about how we've promoted interagency collaboration, how we've aligned supports and legislation and policy, and how we've incorporated lived experience. And then hopefully we'll have some time for discussion. Just a couple of housekeeping items. Please use the question and answer, the Q&A function on Zoom to enter your questions, and my colleague Colleen will be monitoring those questions. Feel free to use the chat, as I think you're already doing, to interact with each other. And just a reminder that all participants will receive a link to a recording of this webinar after the conclusion of it. So if you need to step away or miss some, you can watch the recording. So before I go any further, let me introduce my fellow panelists. I'm joined today by Lizzie Whitehorn, the first Assistant Deputy Governor of Health and Human Services out of the Office of Governor J.B. Pritzker. Amanda Elliott, who's the Chief of Staff for the Illinois Department of Human Services, and Regina Kreider, who is a Senior Policy Analyst at Chapin Hall. And I brought all of us together today so that we could really give you the full picture of how we've gotten to this point. And the full picture starts before my involvement with this. So as you'll see, and I'm about to populate this timeline with a bunch of other things, but the work began probably a few years ago. So, and the earliest thing I thought to note for this discussion was that in 2015, the legislature passed the Custody Relinquishment Prevention Act, which was designed to inhibit the practice that many of you are familiar with, because we've seen it in other places across the country, of taking kids into child custody through the child welfare doorway in order to get psychiatric services paid for. So just kind of keep that in the back of your mind, because legislators were thinking about this issue a number of years back. The governor's office, Lizzie Whitehorn, who's joined us and who will have an opportunity to tell you how she got this work off the ground, formed an interagency children's behavioral health team in 2021. And then in February of 2022, Governor Pritzker announced the Children's Behavioral Health Transformation Initiative and asked me to lead this effort to analyze our service system and make some recommendations in the form of a blueprint for transformation. So we spent the months from February, when that announcement was made, until the end of the year developing the blueprint. And that's what I'll spend the bulk of my time talking about today. Then I'll hand it off to some of my colleagues to tell the story from their vantage point. Soon after the blueprint was released, we began identifying key components of these recommendations that would require legislative change, and that informed the legislative proposals that would be drafted, and we'll talk to you a little bit more about that in detail. The blueprint was submitted to the governor's office in January, and then it was released publicly in February, along with an executive order that the governor signed, installing me as the chief officer for children's behavioral health transformation, as well as requiring that we follow these recommendations to go down a path toward transforming our system. Then we've spent the last few months working collaboratively with legislators, as Amanda Elliott will talk about, and we've recently had some votes in the General Assembly on some of the foundational legislation supporting the concepts in the blueprint. At the same time, our analytic team has been standing up implementation work groups, advocating for that legislative change, but also raising awareness, developing plans to procure and develop the technology that we need. And we have until October 1st to develop a detailed implementation plan. So you can see this is a very methodical process, and all along from the beginning of the initiative through today and ongoing, our engagement with legislators and with state agency leaders and with families and people with lived experience, in addition to ongoing facilitation of interagency staffing efforts. And I'll talk a little bit about that as kind of a pilot test of these efforts. But I'll start with the beginning of my involvement in this work and kind of walk you through the analytic work that we've done to support transformation. So the Transformation Initiative aimed to address the significant behavioral health needs of young people, making services more available to them, but also to improve the transparency and clarity that their families would have in accessing those services. So those were the goals. Now, in Illinois, this thing that I'm referring to as the behavioral health service system is really a patchwork of programs and strategies that are being implemented by 6 different child serving agencies. So I'll just say a few words about them briefly, and then please forgive as I begin to use the acronyms in the rest of this presentation. But first, you've got the Department of Children and Family Services, DCFS, which is the State Child Welfare Agency. You've got the Department of Human Services, DHS, which houses divisions of mental health and developmental disabilities, as well as substance use prevention and recovery. You have the Department of Juvenile Justice, which provides programs and services through aftercare to youth who are discharged from detention or incarceration. And you have the Department of Public Health, which oversees inpatient hospitals. The Illinois State Board of Education oversees 853 local school districts that provide services as required by individualized education plans. Those are IEPs to students who qualify. And last, but certainly not least, I think it's the biggest, you've got the Department of Healthcare and Family Services, which is the state Medicaid agency. So given that when we came into this, we're recognizing that there are 6 state agencies that serve people who have mental health service needs, we had to think about how do we go about understanding how many people need services. So I'll just give you one more piece of background, which is that part of the impetus, I think, for this work was that there were a number of kids in DCFS state custody and custody of the Child Welfare Agency who were hospitalized beyond medical necessity for psychiatric reasons. I think at its peak, there maybe were 55 of them in hospitals waiting to be discharged because there wasn't an appropriate residential treatment site for them. But that was really the tip of the iceberg. And we knew that because of this, all of these state agencies serving kids, we would have to look in a lot of places to even get the data to understand how many kids are in need of care. So we had the data on those kids who were beyond medical necessity, the tip of the iceberg. Then we knew that there were other kids hospitalized, and that data comes from the Department of Public Health. There are kids who are wards of the state, either in residential care through the Department of Juvenile Justice or the Department of Children and Family Services. And then there are two other pathways through state agencies to residential services, either through the Family Support Program at HFS or the Developmental Disabilities Waiver at DHS, or kids whose individualized education plan requires an alternate educational environment might be in residential care placed by their school district. So that, as you can see, there's a lot of complexity there. And then you've got all the kids who get Medicaid billable mental health interventions for any type of service, not just residential. Because we were really concerned with the entire continuum. Now, also, as we began to talk to people, we heard a lot of ideas about what the problems were in our system, and I'll just kind of recap them for you. So there were people who said, we don't have enough services. There were people who said it's too hard to get to the services. The eligibility criteria are opaque or ambiguous, and people don't understand how to get to the services. People said the policies are misaligned and there are perverse incentives that prevent people from getting the services they need through appropriate programs. There were people who said we don't engage with families and system partners, so there isn't enough awareness. And people who said, well, we're missing valuable opportunities because we're not intervening with high quality evidence-based interventions. So I treated all of these as hypotheses going into this and developed a set of research questions. So I've talked about where we were going to get the data and what people's hypotheses were. We were guided by a set of questions that were really focused on the supply and demand dynamics of this. So you've got the supply of services, the demand for services, and then the processes by which people access services. So these are those questions, but I'll go to the next slide to just show you that we had an analytic approach to answer each of these questions. And you're going to get kind of a smorgasbord of these as I show you examples about the analytic work that we did to try to get to answers. So as you can see, to understand demand, we wanted to know, because we were concerned with the whole continuum of services, we wanted to know, well, how many kids are likely to need outpatient behavioral health services? Traditionally, those are estimated through a number like one that the CDC might provide, but we developed some adjusted estimates of those prevalence rates. How many young people are waiting for residential treatment and why? We did a latent class analysis to try to see whether there were meaningful subgroups of kids within the population awaiting residential care. For the process questions, we conducted analysis of policies, and I'll show you an example of that. We developed business process maps and then ran those by families to see if the ways in which the policy said people are supposed to access services were actually experienced in that way by families. And we tested some strategies for working together across the 6 child serving agencies. And then to understand supply, we did some geospatial gap analysis, and I'll show you some examples of those maps. We surveyed providers, particularly of residential treatment, to try to understand our overall capacity. And we talked to many of your states to understand what other best practices are in place across the country that we might pull from. So I've kind of recapped the center column here. That's an overview of all the analyses that we did. And as I said, I'll show you examples in a few minutes. But I want to highlight that there were 2 other activities going on through the entire duration of developing this blueprint. One was deep engagement. So we talked to many, many people, either through advocacy organizations or in individual interviews or focus groups with parents or surveys. We also put out a monthly bulletin to the field to keep everybody apprised of the work that we were doing, because we really wanted to ultimately have a blueprint that everybody could see their voice and their perspective in. At the same time, I've also played a lead role in coordinating the efforts of these 6 child serving agencies, particularly around expediting treatment and placement for kids in the greatest need. So kids with complex and significant behavioral health challenges. And we do that in the form of a weekly staffing call where we go through cases of kids who are stuck. And they might be stuck in hospitals, either in an inpatient unit or an emergency room. They might be stuck in their parent home, but not receiving appropriate services. And so we worked together to overcome barriers, come up with creative solutions. And with the help of a technological application I'll show you in a few minutes, we were also able to accumulate data on all of the cases that we've worked through, and many of which we've resolved in that way. So I'll show you a bunch of examples, and then I'll talk a little bit about implementation before we get to our panel discussion. So first off, I am not going into the details on this, and they're probably too small for you to even read, but this is one example of the policy analysis work that we did. So in this case, this is an eligibility crosswalk looking at all the different types of services delivered by those 6 agencies and all the different eligibility criteria. Now, obviously, this illustrates the incredible complexity, but we also did this because this will allow us, when we have new and improved technology, this will allow us in an automated way to give families immediate feedback on the services and programs for which they are eligible. So another thing I'll show you an example of, many of you are probably familiar with business process mapping, basically a way to create a visual or a picture of the flow of a particular process. In this case, the example you're seeing is a process map of how you get an IEP, like how do you go through the education service pathway to get services. And what we did is we created this using policy documents, and then we used it as a discussion guide with family members to talk through in the context of focus groups. Is this how you actually experience this process? And we learned a lot about how school districts vary and which things are routinely done in ways that are different than what the policy states. We also, I mentioned, talked to people across the country, and we were focused on a set of activities. Well, we talked to people across the state also, but where we couldn't find an example of something in our state, we talked to people in other states. And we talked about respite services for parents. We learned about in-home behavioral health aides to provide parents with additional supervision for their young people. We heard about mobile response strategies that are not just for crisis, but for all kinds of mental health concerns, to provide parents with some education and understanding about the difference between typical developmental issues and mental health concerns, and the other things you can see on this list. So it gave us really a broad array of strategies to pull from, and maybe we even spoke with some of you on this call. So for the more quantitative analytic work that we did, I mentioned that we were trying to come up with estimates of outpatient behavioral health service need, and then we use those to conduct gap analysis to see if we have enough of what we need. But one of the important things that we did was, instead of the traditional approach to estimating service need, which involves taking the like maybe the CDC's estimate of 21.3% and applying that to the population, what we did was we developed a method for adjusting those estimates based on some other characteristics that we know elevate mental health service need, namely economic hardship and exposure to community violence, in addition to individual characteristics. And once we incorporated all of that and compared it to where we have community mental health services, we were able to come up with a much more targeted map that highlighted, and you can see on the right, the map on the left is where our community-based service providers are. The map on the right is a scoring methodology that we applied to show how much access to resources, to community-based mental health resources, people have. So then that gives us a guide if we focus on more infusing those communities in red with more resources to get to a more equitable distribution and access. I mentioned we also surveyed providers of residential treatment, and what you'll see on this map is, for the first time ever, all those state agencies that purchase care, we put all of their occupancy, vacancy, utilization data in one place. And this provided really a proof of concept that became the justification for something that now is in legislation, where all of this information has to come to a single state agency so that we can actually manage this as a system instead of a patchwork. Okay. Colleen, I know you're monitoring questions, and I, as always, am talking very fast. So I'm happy to be interrupted if there's any relevant questions that I need to answer in order for people to stay with me.
Okay. Erica Fleischer asked, which state had good examples that you learned from?
That is a great question. So And I often get asked the question, like, which state should we model our system? Like, is there one state that's like kind of the utopia of children's behavioral health? And of course, there isn't. But we heard about a lot of good examples. We heard about good examples in New Jersey where they use mobile response, not just for crisis. We saw examples of centralized portals that we're modeling some of our work on in Sacramento and in Colorado. We talked to Washington State. We talked to Minnesota and Alaska. Both were using in-home behavioral health aides. So I have a lot of examples of places that had good practices, but I wouldn't say there was one place that does all of it right. And just as I would say to all of you that as you see the recommendations we came up with, I don't know that this same prescription would be the things that you need in your state. I do think that this methodical process of engaging, talking to people, working across both the executive and legislative branch is a way to get to those answers. But thanks for your question.
Can I read this other one, Dana? It's relevant here too.
And then we'll have more time for questions at the end too.
Right. So this is from Elizabeth Carter. She says, are there other states that are more successful with regard to residential settings for the hard to place adolescent patients? Our biggest challenge is the lack of facilities to discharge our patients because their length of stay is absolutely prolonged beyond medical necessity due to having no place to discharge them.
And that is a dynamic that I think is happening in a lot of places. And I wish I had the answer to that. I do know, I mean, there are some places that have tried to halt the practice of placing kids out of state, and in doing so have been forced to confront some of the challenges in their own capacity. But I think, and we can discuss it more, during our discussion time at the end, and my panelists might have thoughts on this too. But I think that given the workforce shortage we're experiencing, paired with the uptick in the need for those services, paired with some other shifts in our system, some of which are needed. I mean, many of you are a child welfare audience, and in my work in child welfare, it's all been about reducing reliance on congregate care. But then all of a sudden you get to this mental health sphere, and you're like, well, but wait, we need enough beds for the kids who really have acute problems and require this level of supervision. So it's an interesting tension. But I'm going to ask if we can stick a pin in that question and get back to it when we get to our discussion. Okay, so I'm showing you this because this is a pic. So one of the first things I did when I realized that we were doing this interagency work already was to stand up a piece of technology that would let us overcome the legal and technological barriers to talking to each other. Because a lot of times what people say when we're asked to work across agencies is we legally can't share that information, or our systems don't speak to each other. So we overcame those problems with this. And in doing so, we did something else, which is this created a data source for us to track our work on these cases. And to date, we've staffed about 160 cases using this tool, and we've resolved, now we're up to about 50% of them, which might not sound impressively high, but many of you are familiar with the acuity and severity of these cases, and it really is challenging to come up with stable resolutions. So this portal asks the user, and it's open to the public, so legislators enter cases, hospital social workers, parents might enter a case. It is not broadly available because this was a test case, like a pilot. We're in the process of building the portal that will be more robust. So it asks a series of questions, and it helps us to work together to expedite those cases. Now, that's kind of some of the analytic stuff we've been doing, and get back to some pictures and the implementation. But I want to go back to this idea that if we have multiple state agencies that are serving families, particularly as it relates to the residential treatment, it means that what you get often depends on what door you come in, and you don't know where you're going. And you're asking for this undifferentiated residential services. That's what we heard from families and people who work with them. So we're trying to move from a system that looks like this, where navigating this is like you're going through a vast, dark, scary, unmarked forest, to something that looks like this, where no matter what doorway you enter, you get information and you get navigational assistance, and there's a clearly differentiated array of types of services that you might need. But in order for families to experience this, the system actually has to look like this, where you have a centralized portal. So we're going to talk about that in a moment. Our goals for improving our system were to, one, adjust capacity, to streamline processes so that we can access the services we have, to intervene earlier, because in the context of this workforce shortage, we can't solve this problem by adding endless capacity. So we have to reduce demand, and we do that by intervening earlier, making that possible. We also have two other systemic goals: to increase accountability and transparency, and to develop agility so that our systems can shift when the needs of the population shift. So this might be the moment you've been waiting for. These are the 12 recommendations that are in the blueprint. And as you can see, 4 of them are focused on centralizing and streamlining. 2 of those are pieces of technology, the care portal and the resource referral technology. 4 of the recommendations are around adjusting capacity, and those include using regular data analysis to inform adjustments, but also standardizing rates, making it easier for new providers to partner with the state. And then 4 of them are focused on that intervening earlier, and that includes universal screening in education and pediatrics, and rebuilding the workforce, and fortifying community networks, and standing up parent leadership. All of these recommendations and more can be found in the blueprint, which I will give you the QR code to it at the end of this presentation, but I'm sure you probably already have it from registering, or someone can put it in the chat. But the point I want to make here is that I showed you those 5 target goals. They are listed down the left-hand side. There's no one silver bullet. You can't accomplish any of those goals with one of these recommendations. To do any of them, you need to do 6 or 7 different things. So this matrix kind of helps me make this point when people might be inclined to pick and choose among strategies. We really need to do all of these things in order to get to a transformed system. And you can see the 12 recommendations are across the top. For those of you who like to see things as pictures instead, this is the same 12 recommendations. Now you've seen them in a list and a matrix, and this is a picture showing you that it kind of all starts with this structure, this centralized portal that we're working on building. Then there are process adjustments surrounding that. Then we get to the capacity adjustments, and undergirding all of this is regular data analytic review. Now, as you might have guessed, we're not going to accomplish all of this all at once. And my vision for this is that these are like trains leaving a station, and some of them are going to get to their destination shortly, and some of them are going to take a lot longer, but they're all leaving now, meaning we don't have the luxury of waiting to work on some of these for a year or 2. We have to start working on all of them now, which is very complex, but I think worth doing. So this is just kind of a mapped out list of what we think will be the shorter term accomplishments, the medium term, and the longer term. And to get there, there are a number of things we have to do to support implementation. And as you know, if you're familiar with our work at Chapin Hall, we spend a lot of time on strategic implementation support that involves attention to these 5 areas. So leadership, governance, and strategy, who's going to oversee this and be responsible for it. Policy and fiscal alignment, and that's the legislative work that Amanda will talk about in a few minutes. Data analytics and evidence use, ongoing analysis to make sure that we are responding to an empirical basis of what we need. Practice and implementation support, understanding who's going to do the work and what do they need for training and materials and support. And then continuous quality improvement to ensure that we have our eye on a set of metrics to know that we're moving in the right direction. For each of these 12 recommendations, all these trains leaving the station, there are a set of activities, like a progression to getting to full implementation, that starts with design, engaging with subject matter experts, developing specifications and refining them. Then we move into planning, really defining and operationalizing what we're doing, and that includes job descriptions for new roles and really developing like the business process maps for the technology. Then we have the opportunity to install new strategies, test them, train people, and communicate about them. And then we get to full implementation where the new strategies are required and we monitor key indicators. So for each of those 12 recommendations, there is, I'm not going to show you all 12 of them, but there's a timeline around designing, planning, installing, and implementing where steps are laid out. And this is really serving as our roadmap, like our guide to how we're going to get there. In addition, we've stood up implementation work groups, and I've kind of bunched them in these 4 areas, which I think are qualitatively different from each other. So we have one work group focused on the technology that's needed, one work group focused on program development, one focused on schools and community, and one focused on data and fiscal. And those groups are all meeting at a regular cadence to focus on their recommendations, with a core group of interagency people who are all working together on this. Now, I'm going to, if there are, Colleen, are there any other questions for me? Because I'd like to transition to the panel discussion, if not.
There are a few questions. A question from Michelle Fanning says, we have had to send kids out of state due to the need for locked facilities, as we do not have locked facilities in Illinois. Is there discussion of opening locked facilities in Illinois?
Well, there's discussion of a lot of things, but I can't speak to specific plans that agencies have. I will say that this blueprint has provided some much clearer guidance on who needs what, so that latent class analysis, which I'm happy to talk to you about in more detail offline, to help, it gives us a little bit of, oh, I can talk about it for a moment here. So that latent class analysis basically let us see that there's about 15% of the people in the queue waiting for residential who have acute mental health needs, like need something like a QRTP. There are a couple of subgroups who maybe could be served in community settings with wraparound services. And then there's also a subgroup of kids who have out of control explosive behavior that is dangerous to people around them that may need to be in more secure settings. But we are not at a point of, I'm not in a position to answer that question about what will be developed by the state agencies, as we're still in the process of working that out. So I'm gonna take a moment to reintroduce the panel, starting with Lizzie Whitehorn, who is really, this is her brainchild. She got the ball rolling for this. And Lizzie, I'm gonna stop sharing my screen so that people can see you and I. If I can find the button. And I'm gonna just ask you to tell us a little bit. I have to switch my camera too, I guess. Let's see, there.
Technology.
Yeah, I know. So I'm going to ask you to start by talking about what prompted the governor's office and you to take action on this, and how'd you get it off the ground?
Sure. Thanks, Dana. And thanks everyone for being on this webinar. We're really excited to be sharing our work so far, with a lot more to come. So I think, you know, several things just came together at the right time to get this kicked off. These issues around not having enough residential placements, not having the right services available for kids had been something that our office and the governor was aware of from, you know, even before he took office. During the campaign, we heard from legislators and from advocates and from parents about these issues. But I think in the first few years of our administration, we dealt with a lot of issues around DCFS kids who were in the emergency room or psych hospitals beyond medical necessity, BMN. I think Dana talked about that. But we knew and were struggling to explain more broadly that the issue was broader than that. That, as Dana showed, I love her little triangle with the tip of the iceberg and then the rest of the groups that were focused on, that it was much broader than DCFS kids. And so something else that came up shortly before we really got started was a couple of, I'd say, higher profile cases of families who were trying to get their kids placed in facilities outside of the state of Illinois because they couldn't find the right placements here that had capacity, and trying to get those approved through the State Board of Education process. And so a lot of these things were percolating, and we also seemed to have a moment in time where COVID work had finally calmed down a little bit, and we could look up and see, okay, what is it that we really had come into office wanting to work on? And one of those things was really to help the most vulnerable kids in our state, and to help families navigate processes to get the services that their kids needed. So I had conversations with the leaders at all of the state agencies that impact this work. And we had momentum really from those leaders to want to come together and think outside the box and put their best thinking together, the best research, and figure out what we could do to really make a difference.
Great, thanks. And what about the interagency collaboration, setting that up specifically, given that that's something that the state has struggled with?
Yeah, so that was really a big part of this. And I think, you know, this project is exciting substantively because of the work that Dana explained, but also from a process perspective, because at least in the state of Illinois, this involves 6 different state agencies, as Dana explained. And so I knew it was going to involve having to bring them together, get a really deep and better understanding of the programs that they run, how their funding works, what are the strengths of those programs, what are the challenges with those programs, and how those agencies work. I think the way our office of the governor is set up was uniquely situated to help facilitate some of this work. There are 4 deputy governors who oversee different groupings of agencies. And so I work with the Healthcare and Human Service agencies, which is most of the agencies who are involved. And then, another deputy governor over education. And then actually our lieutenant governor's office works on a lot of the justice issues. And so by working with the agency leaders and also with my leaders in the governor's office, we all sort of came together to agree upon a vision and a high level set of goals on what we wanted to work on. And those were really very similar to what Dana described earlier. I think, from a very high level, we were looking at how can we make this system easier for families to navigate? And how can we focus on both increasing residential placements to meet the needs that exist, and how can we increase the availability of services in the community so that some of the cases don't escalate unnecessarily into that higher level of need. And we were really focused on the most complex and significant, or children with the most complex and significant needs. And then, the next level down was really figuring out, bringing together an interagency team with project managers from 3 of the key agencies who aren't necessarily subject matter experts, but knew how to navigate within their agencies to move things forward. And they brought together a group of subject matter experts from all of the agencies. And it was about both sharing information, but also building trust. So these people have worked together for years, but not necessarily in this way. And so it generated a lot of excitement among people who had been working for state agencies for years and years and years and had never seen real change happen. And of course, after a couple of months, they really quickly came to me and said, this is so exciting, this is great, but we need more dedicated resources. And that's when we were able to bring Chapin Hall and Dana on board to really continue to move the project forward.
Thanks, Lizzie. There's no way to overstate the role of the governor's commitment to this and your commitment to this. This would not be happening if you did not have this steadfast dedication to solving this problem, and also a willingness to recognize that it might involve some disruption and doing things in different ways. And so it really is an incredibly empowering experience as a policy researcher to be able to partner with government in this way to solve a problem. There are a couple questions in the Q&A that I saw Jessica's and Amy's, but I'll wait to answer them. But I want to speak about the legal thing and also about the portal. But I'm going to turn to Amanda Elliott now, who prior to her role as the Chief of Staff at the Department of Human Services in Illinois, was the Executive Director for Legislative Affairs at the Illinois State Board of Education. So, and almost everything I know about the legislative process, aside from what I learned from Schoolhouse Rock, comes from Amanda Elliott, who has given me a crash course in such things over the last few months. So, Amanda, tell us a little bit about the best way to engage and work collaboratively with legislators when many of them have their own long histories or individual goals for a process like this?
So it's important to engage legislators, I think, early and often. As soon as Dr. Weiner was appointed, we made sure that legislators were aware of her coming on board. They were invited to the press conference to make the announcement about her appointment, asked to speak, and we have been engaging legislators throughout the process. You're absolutely right. There are legislators who have worked on this for decades. They feel a lot of, I think, ownership and justifiably so. They put a lot of work toward this effort and want to make sure that that they are a part of the results. So we have had multiple meetings over the last year with a variety of legislators, and just keeping them updated on what we were doing. This legislative session in Illinois, legislative session is every year from January through May. So we started last fall developing the bill that would be the initial piece of legislation to start this work. I think my emphasis is on the word initial. When we started meeting with bill sponsors, they had all of these other ideas that they have been prioritizing and working on, like I said, for decades. And so trying to really, I think, set expectations and also make it clear that we value your ideas. Let's see how we can work to incorporate them. And if we can't, then acknowledge why, and that this is the year one bill. We will more than likely have to come forward next year and possibly in future years as we continue along this process. So just making sure that they are brought along, engaged, and are, I think, true partners in the process.
Mm-hmm. So I'm just going to mention there are a number of tensions in this legislative work, and Amanda, you can pick and choose which you want to speak to, but I'm thinking of the tension between the legislative branch and the executive branch, although right now they feel often to be aligned, but there are tensions there. There are tensions between legislators who have different ideas about how to solve the same problem. And then there are also tensions that arise from the constituents of legislators where they feel pressure to act or act in a particular way. And Amanda and I have found ourselves on the phone with many a legislator to explain how we're handling a particular case, actually. So Amanda, I don't know, those are kind of some of the stickier things that we get into. I don't know if you want to pick any of those to say a few words on.
Yeah, one that comes to mind immediately is just the legislators who are hearing from parents and families when they're in crisis and they have a child who needs a bed. I would get texts on the weekends saying, this child has been in the emergency department for a certain amount of time. What can we do? How can we assist? What can our role be? Not just in the legislative process and helping to move bills along, but what can we do for these individuals and families? And so the portal that Dr. Weiner helped develop, which I personally think as a part of this process is probably the single most transformative piece of the work. I don't know if she would agree with that, but that's my personal opinion. Having a place where people can go and just put information in about a child, but then that is actually acted upon is really incredible. It's not just going in some kind of black box. And we gave legislative offices access to that portal. So they all have the ability to go in. If they know about one of their constituents, they can absolutely text me on the weekend and I will make sure that we're elevating that. But also knowing that their district office staff can go in, input information about a child, and it will be acted on by this interagency team. And Dr. Weiner can speak probably better to the results of that, but we have addressed multiple cases that have come in through legislative offices and others through that portal. And part of the legislation is expanding that, making it public facing so that you can go to a website. And we are working currently at DHS to build out the specs of that larger portal. But I think that's been one way that we've been able to manage the tension between the legislators and the executive branch.
Absolutely. And Amy, I know you're hi, Amy. Good to hear from you. I know that your question was about the portal and the new and improved portal that is part of the blueprint that we're working on now will be public facing, and parents will be able to go to it to enter information about a young person with any level of need, find out what they're eligible for, and then if needed, they will be contacted either by a parent navigator or by a resource specialist who will help them continue to navigate that process. I'm happy to talk more about that in the discussion, but now I want to hand it over to Regina Kreider, who I'm thrilled to say is part of our team, and I'm so grateful to have somebody, a parent with lived experience, in a leadership role as part of this work, because I don't think any of this is transformative if it doesn't actually meet the needs of families. So Regina, maybe say a few words about your perspective on when we should be involving parents in these discussions and what parents need to engage effectively as part of this process.
Thank you so much for asking this question. It's really important. And so what I like to say is that when you want to engage parents, you need to engage them from the very beginning when decisions are being made, right? They need to have a seat at the table when plans are being made, and that includes every single plan, from when programs and services are being designed, when frameworks and logic models are being developed, even when policies, budgets, job descriptions are being crafted. And I would even go as far as to say, even when websites and promotional material is being created. Parents should be involved at the micro, meso, and the macro levels of systems involvement on every level. Their voice should be infused throughout that whole entire planning process, implementation, every aspect of it.
And are there particular, I agree with you completely, and even just in the, has it been months that you've been a part of our team? Even in just that period of time, you've flagged things for us to say, hey, this isn't going to work for a parent, or we need to ask this question earlier on, demonstrating that value. But one of the things I think we not struggle with, but we need to figure out a good way to do, is to have this channel where we can easily access parents and where they have the readiness to participate in these conversations. And you've been playing a valuable role in that respect, because you've been now a parent liaison who can be the first line of like speaking to parents and figuring out, do they just need information, or do they just want us to know about their experience, or do they really want to partner on things? Is there anything you can share about like the best way to prepare parents for being a part of that process?
Yeah. So initially, I would say that there needs, for those parents who need it, not everyone will need an initial investment of time and resources to help prepare them to be able to participate in meetings, because what you don't want parents to feel like are tokenized, or that they don't have a real voice at the table. Parents don't want to feel like they're incompetent. So it's important that they are prepared. So some parents, you're going to have to help prepare them for that process. You know, people like you and I have done meetings all of our lives. And so it's kind of like in our blood, and we're ready and we can do this. But there's some parents who will need some of that initial investment. And if you're working with parents, there needs to be some time taken to develop relationships to see what those needs are to help prepare them. The next things I would say is that parents want to have an honest, open, two-way communication. They need for you to be able to be transparent with them and talk with them as equal partners that are sitting at the table. That's going to help them better prepare and engage in that process, right? They need meetings, and we've said this a million times, they need meetings to occur at times that are realistic for them, right? Not during working hours when they may be at work. And also they need to be parent friendly, and that may include helping with transportation. It may require childcare, but it's also important that they're culturally and linguistically responsive so that parents can participate regardless of what so that there aren't any like language barriers or different things of that nature needs to be taken into consideration. And also parents need to know that their voices are heard and are valued. Once again, a parent doesn't want to be at the table for just to be a box that's checked off. They don't want to be tokenized. They want to feel valued and want to be respected. And finally, I would say they need to have access to useful, usable and understandable information and data. So those are just a few things that I would suggest that need to take place for parents to participate.
And you and I are going to work on developing a curriculum for that too, so that
Yes.
parents have that usable information.
Right.
Okay, that's great. And all of you, Lizzie and Amanda and Regina, I appreciate all these perspectives. Hopefully we can collaborate in answering some questions, but I want to say a couple words just of questions I've seen in the chat. I see there's a lot of interest in the portal, so I just want to make I want to say a few words about it. So the portal that we built in June of 2022 was a pilot, like a test case example to see if this could work. One of the things that we had to do, and Jessica, this gets to your question of how did you broker these legal agreements? One of the things we had to do was talk to 12 attorneys from 6 different agencies to negotiate a consent form that everybody would be comfortable with, that would be presented to a parent to say, can we all work together and talk to each other in order to help get your child services? Once that parent signs that consent form, then we are all free to talk to each other in the context of the portal, which is hosted at a secure server at a state agency. So the information is secure. All the agencies have access and login information, the people who are entitled to that information. And the consent form gives us permission to talk to each other. Now, there's a whole bunch of kinks we still have to work out. Like the consent form doesn't allow us to get back to the person who entered the case. So if, for example, a hospital social worker or an attorney or a legislator enters the case, the consent form doesn't let us keep those people up to date on what's happening. Although they oftentimes notice that the case got resolved because we put all this effort towards it. The other thing I will say, I know many of you are saying, can we have the link to the portal? So we are working on building a new and improved portal that will be accessible to everyone. And Amy, to answer your question, yes, foster parents, teachers, anybody who's trying to get help for a young person. Now, the portal is just, as I said, there's no one silver bullet. The portal is one part of a suite of technological tools. We are also working on developing a statewide resource referral database that everybody will have on their mobile device. So that if you happen to be like a school security guard and somebody needs a food pantry or something, you could give that information to someone in that way. But if you're a parent or someone else concerned about a child and you want to link that family or that child to services, you would, once this portal is done, which I hope will be during 2024, you would enter that information, and then we have a very complex flow chart, and this gets to someone else's question about how will you prioritize these cases. We do have an algorithm and we've been working as an interagency group now for over a year, so we have observed what are the elements of acuity and severity that should prioritize cases. The number of days kids have been maybe beyond medical necessity, the current urgency of their case, whether other people are at risk. All of those things will go into the prioritization. But in the newly envisioned portal, there will be like every morning, a triage specialist will get a report of everything that was entered. It will be prioritized. Lots of the things will be automated. So the short answer is I'm not going to put the portal link in the chat because I think the volume might overwhelm the small team of people who are still doing this work right now. But in the near future, we hope to have a much more robust, centralized place. Colleen, while I'm talking, I haven't been monitoring the.
Sure. You have answered many of them already. So there are 2 remaining questions. One from Christy Hudson: how are ombuds programs involved with the portal? It seems potentially redundant with the purpose of these offices.
Yeah, so one of the big challenges in doing this work was I really envisioned it as weaving together all the existing solutions as opposed to like starting from scratch and building a whole bunch of stuff. So if I could show you the process map for the portal, it actually includes like branches that go to existing warm lines and hotlines. It includes the CRSA, the Community Residential Services Authority. I hope I said the acronym right. That will be repositioned as navigational assistance for parents, because one of the things we heard from parents where they really needed help, like at the elbow support to navigate the IEP process or to navigate discharge from hospital. And so we will be using these existing resources. So existing ombuds programs would just be part of that network of people who could provide navigational support, who could provide informal assistance. And so I think learned about many, probably hundreds of resources across the state, but if there are others that you think we might not know about, what I will put in the chat is my email address so that you all, I think if you can see the chat, so that anybody, you have information that you think that we might not have incorporated, feel free to shoot me an email and let me know about it. And was the last question Alicia's about stigma?
That's right.
Yeah, so we've been talking a lot with our partners at the Department of Public Health about this because I think they really have a role to play in enhancing communication and reducing stigma. I will say that my observation is that the current generation of young people seem to have a little bit less stigma, although that may not necessarily translate to their families having less stigma around acknowledging and seeking help for mental health problems. But again, I think there's a lot of partnership that needs to take place. And as Regina mentioned, communication materials that really speak to families in their language, but also in the accessible and kind of open way that might encourage families to seek help without needing to get heavily involved in a state system, because many families don't need that. The recording will be sent to everybody who is registered for this webinar. So once it's edited down to, I don't know what they'll edit out, maybe if I said a lot of ums. Anyway, Lizzie, Amanda, Regina, anything to add before we say goodbye to people this afternoon? We're really excited about our collaboration and wish you the best of luck in your efforts. Oh, wait, I did have one more slide to share, which is the QR code as promised. See if I can get it up there before we lose people. I gotta change the display settings. Here we go. Swap. And there you go. So if you scan the QR code, you will be linked to the blueprint so that you can read it yourself and learn more about the work that we're doing in Illinois. And thank you so much for participating in our webinar this afternoon.